Today is October 20th, 2022, and I'm pleased to call our ACIP meeting to order. I will now take roll call for the members only. We again, name, affiliation, and any conflicts of interest. So I'm going to start today with Dr. Talbot.
Hey, good morning. I'm Kip Talbot. I'm an associate professor of medicine at Vanderbilt University Medical Center. I'm in the Division of Infectious Diseases, Departments of Medicine and Health Policy. Oh, no conflict.
Thank you. Dr. Chen.
Good morning, everyone. Wilbur Chen, professor of medicine. I'm at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I have no conflicts.
Thank you. Dr. Lair.
Dr. Jamie Lair, private practice, family medicine, Ithaca, New York, no conflicts.
Thank you. Ms. Bata.
Good morning, Lynn Bata, public health nurse, clinical immunization consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you. Dr. Brooks.
Good morning, Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation, South Los Angeles.
Thank you. Dr. Daly.
Matt Daly, Senior Investigator, Kaiser Permanente, Colorado, University of Colorado School of Medicine, no conflicts.
Thank you. Dr. Bell.
Sorry, Beth Bell, Clinical Professor, Department of Global Health, University of Washington, no conflicts.
Thank you. Ms. McNally.
Good morning, Veronica McNally, President of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Sanchez.
Pablo Sanchez, neonatologist and pediatric infectious disease at Nationwide Children's Hospital and The Ohio State University in Columbus. I have no conflict.
Thank you. Dr. Shaw.
Good morning. Nirav Shah, the Director of the State of Maine Center for Disease Control and Prevention. I have no conflicts.
Thank you. Dr. Long.
Good morning. This is Sarah. I'm Sarah Long, pediatric infectious disease doctor and professor of pediatrics at Drexel University College of Medicine in Philadelphia. I have no conflict to disclose.
Thank you. Dr. Cotton.
Good morning, Camille Cotton. I'm the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts.
Thank you. Dr. Sineas.
Good morning. I'm Sybil Sineas. I'm an internist and pediatrician, Associate Professor of Medicine and Pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Paling.
Good morning. I'm Kathy Paling. I'm Professor of Pediatrics and Epidemiology and Prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict.
Thank you. And I'm Grace Lee, Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts. So we are...
Note Oliver Brooks, I have no conflicts.
Oh, thank you, Dr. Brooks. Thank you, team. I appreciate that. So we will now proceed to the agency updates. And we should start with the Centers for Disease Control and Prevention.
Good morning. I beg your indulgence. We have a lot of updates to give. It'll be a little bit longer than usual. So I will begin with current efforts on maintaining childhood vaccination coverage. During the 2020 and 2021 school year, national vaccination coverage among kindergartners dropped in comparison to pre-SARS-CoV-2 pandemic period. CDC is working to recover ground lost during the pandemic and is working with healthcare providers and families to get the children caught up on recommended childhood vaccines through its Back to School call to action, which outlines steps to encourage catch-up vaccination, as well as its Let's Play Catch-Up communication campaign, which encourages parents to prioritize the need to bring their children up to date on routine childhood vaccinations. In the area of seasonal influenza, this month, the National Foundation for Infectious Diseases and CDC hosted joint influenza pneumococcal press conference at the National Press Club in Washington, D.C. to kick off the 2022-2023 influenza season. CDC has partnered with the Ad Council and the American Medical Association for their annual Get My Flu Shot campaign, which has also been translated into Spanish. This campaign, with emphasis on Black and Hispanic audiences, encourages the American public to get vaccinated against influenza for the coming season. The first weekly Flu View report for this season was published on October 14th. Early increases in influenza activity have been reported in most of the United States, with the highest levels of activity occurring in the southeast and south central parts of the country. This may portend a significant influenza season. No pediatric deaths have been reported to the CDC for the current season. However, last week, unfortunately, the CDC received reports of 2 new pediatric deaths from the previous influenza season, bringing that season's total to 43 deaths and reminding us about the significance of this disease for children. For the current season, based on current claims data for 18-year-olds and older, approximately 12 million doses of influenza vaccination have been administered in pharmacies and physicians' offices as of the week of September 24th. Polio, you all heard about the outbreak that occurred in New York yesterday. Just some highlights. CDC has been actively involved with the New York State Department of Health leading the response. CDC is supporting them. CDC has been working at the local, state, and international levels to control this outbreak. We have deployed staff to New York since August 4th in efforts to assist investigation and vaccination efforts in Rockland and Orange counties. Among its many salient actions include for the CDC conducting testing of poliovirus and wastewater samples in New York and neighboring states, providing confirmatory testing for clinical specimens, collaborating with Israel, the United Kingdom, and the World Health Organization to understand the origins and relatedness of this virus to those found in those countries, ensuring safe and secure handling and transport of potentially infectious materials through the National Authority of Containment, and lastly, facilitating the procurement of polio vaccine for the affected areas. The latest wastewater report will be published at the end of this month in the MMWR. The acute flaccid myelitis patient under investigation reports have declined over the last 4 weeks, indicating that the expected surge in AFM cases failed to materialize this year. So it's now the 5th or 6th year that we've not seen a large increase. Concerning meningococcal disease, Florida is experiencing an outbreak of serotype C meningococcal disease, primarily among men who have sex with men, MSM, since December of 2021. This is one of the largest meningococcal outbreaks among MSM in the United States history. As of October 18th, there have been 35 cases, including 7 non-MSM cases and 7 deaths. MSM living in Florida are recommended to receive meningococcal vaccination. MSM who are traveling to Florida are encouraged to talk to their healthcare providers about getting men ACWY vaccine. CDC has been responding to this outbreak with laboratory epidemiology and communication support using multiple channels to provide vaccination. With regard to measles, as of October 18th of this year, provisional data indicate that there have been 29 cases of measles in the United States. 5 jurisdictions have been involved: Arizona, Minnesota, Ohio, Virginia, and the state of Washington. All cases have occurred in unvaccinated individuals, and all but 1 case were in individuals less than 20 years of age. All confirmed cases were associated with importation by individuals who have traveled to Kenya, Somalia, and Tanzania, where measles outbreaks are ongoing, again highlighting the importance of pre-travel vaccination for children. With regard to monkeypox, as of the 19th of October, there have been 27,635 confirmed cases of monkeypox, orthopox cases in the United States. There were 539 new cases reported between October 13th and October 19th. CDC's mission to contain this multinational outbreak of monkeypox has been through preventing continued spread of disease by education, medical countermeasures for treatment and post-exposure prophylaxis, expanding laboratory testing availability, coordinating vaccination activities in the United States, and monitoring travel-associated cases. Lastly, I want to turn to a success story from the ACIP. This concerns varicella. In 1995, the ACIP took the scientifically informed yet bold and move to recommend routine immunization with varicella vaccine. The United States was the first country to introduce varicella vaccine into routine childhood vaccination schedule and program in 1995. Over the quarter century of this effort, the United States has prevented among children 0 to 49 years of age an estimated 91 million cases of varicella, 238 hospitalizations, 1.1 million hospitalization days, and almost 2,000 deaths. This has led to a life year savings of 118,000 years and a net societal savings of over $23 billion in that quarter century. Congratulations to the ACIP for their wise decision. That ends my report. Thank you very much.
Thank you very much, Dr. O'Mara, for that update and for the good news. Next, we'll move on to the Centers for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hance, and I have a few updates for CMS. First, I'm sure that you are all aware that the Inflation Reduction Act included immunization provisions that made changes to adult vaccine coverage and related costs for beneficiaries in Medicare, Medicaid, and the Children's Health Insurance Program. For Medicare, Part D generally covers commercially available vaccines, except for those covered under Part B, as in B as in boy. Starting in January 2023, Part D plans may not apply a deductible coinsurance or other enrollee cost-sharing requirement for Part D covered adult vaccines recommended by the ACIP. CMS has issued guidance to Medicare Part D sponsors to address this provision. For Medicaid and CHIP, beginning in October 2023, coverage of ACIP recommended adult vaccines without cost sharing is mandated for enrollees who receive coverage under traditional Medicaid and for all Medicaid medically needy enrollees in specified states, and CHIP enrollees who are 19 years of age or older. And CMS anticipates releasing guidance on this provision. Shifting to seasonal flu, CMS has made updates to cms.gov to provide updated seasonal flu vaccine information and pricing for the 2022-23 flu season. And in addition, just wanted to highlight that CMS continues to amplify guidance regarding COVID vaccines and is issuing press announcements whenever there are changes around COVID vaccines. And that's the end of my report. Thank you very much.
Thank you so much. And I just wanted to say thank you for continuing to ensure access to vaccines for our adult populations. Next, we'll have the Food and Drug Administration. We'll move on to Health Resources and Services Administration.
Good morning. This is Melinda LaSalle. The National Vaccine Injury Compensation Program, or VICP, continues to process an increased number of claims. In fiscal year 2021, petitioners filed 2,057 claims with the VICP, and nearly $208.3 million was awarded to petitioners, and $36 million was awarded to pay attorneys' fees and costs for compensated and dismissed cases. In fiscal year 2022, petitioners filed 995 claims with VICP, and nearly $196 million was awarded to petitioners, and $34.2 million was awarded to pay attorneys' fees and costs for compensated and dismissed cases. Fiscal year 2023 data collection has now begun. In addition, as of October 12, 2022, the VICP had a backlog of 1,536 claims alleging vaccine injury, which are awaiting review. As of October 1st, 2022, 10,323 claims alleging injuries or deaths from COVID-19 countermeasures have been filed with the Countermeasures Injury Compensation Program, or CICP, including 7,412 claims alleging injuries from COVID-19 vaccines. 6 COVID-19 countermeasure claims, all of which are COVID-19 vaccine claims, have been determined eligible for compensation and are pending a review of eligible expenses. 48 COVID-19 countermeasure claims have been denied compensation because of the standard of proof for causation was not met and/or a covered injury was not sustained. In addition to claims alleging injuries or deaths from COVID-19 countermeasures, as of October 1st, 2022, the CICP has received 2 claims alleging injuries from monkeypox vaccine. More information about both programs can be found at the HRSA.gov CICP or VICP website. That's the end of my report. Thank you.
Thank you very much. Next, we'll move on to the Indian Health Service.
Good morning. This is Dr. Matthew Clark. The Indian Health Service continues to confront the SARS-CoV-2 pandemic and its significant impact in tribal communities. Collaborating with our federal, tribal, and urban Indian organization partners, the IHS has prioritized equitable access to COVID vaccines throughout Indian country. To date, participating federal, tribal, and urban facilities within the IHS jurisdiction have administered over 2.3 million COVID vaccines. Following recent regulatory actions by the FDA and CDC, the IHS rapidly communicated information regarding bivalent COVID vaccine boosters. We anticipate that a majority of our service population will be vaccinated in their IHS medical home, and federal, tribal, and urban facilities are now actively engaged in implementation. To date, nearly 40,000 bivalent booster doses have been administered throughout Indian country. Across its 3 surveillance systems to date, IHS COVID vaccine safety monitoring has demonstrated a reassuring safety profile consistent with other national vaccine safety surveillance systems. Meanwhile, the IHS routinely collaborates with the CDC and engages with tribal leaders to support vaccine confidence among the American Indian and Alaska Native service population. Beginning this past spring, IHS has been working also proactively to ensure access to Jynneos vaccine to mitigate the risks of monkeypox in tribal communities. Over 10,000 doses of Jynneos have been pre-positioned across our 12 areas. On September 9th, IHS announced a monkeypox PrEP initiative to expand eligibility for Jynneos vaccine to include not only PEP and PEP++, but also pre-exposure prophylaxis for at-risk populations. In collaboration with our federal and tribal partners, IHS has also implemented a simple process for onboarding sites to participate in the National Monkeypox Equity Pilot Program to further expand access in our vulnerable service population. Finally, I'm pleased to report that in the coming weeks, IHS will be rolling out a new national vaccine strategy. The E3 vaccine initiative is designed to promote access for every patient at every encounter to every recommended vaccine when clinically indicated. This includes all ACIP recommended vaccines in all age groups. We look forward to continued collaboration with our tribal, urban, and federal partners to ensure access to safe and effective vaccines across the age spectrum for American Indians and Alaska Natives served by the Indian Health Service. That concludes my report. Thank you.
Thank you, Dr. Clark. Next, we'll move on to the National Institutes of Health.
Good morning. This is John Beigel from the National Institute of Allergy and Infectious Disease. Just a few high-level updates that we think would be of interest to the committee related to our vaccine work. Most of our updates are actually outside of COVID, reflecting the need to continue advancing these other vaccines. For hepatitis B, the NIH updated its strategic plan on research to cure hepatitis B. It's a roadmap that tries to plot a course towards ending the hepatitis B epidemic, focused on treatment strategies, but also vaccination strategies and screening. As far as influenza, the trial started, we continued to make advancements for universal influenza vaccines, and another clinical trial started at the clinical center, the NIH Clinical Center, for a universal influenza vaccine that, at least in preclinical models, suggested might again develop broad neutralizing responses. We also continue to worry about pandemic flu and have started additional strategies, additional studies for H5 influenza. This most recent trial that we'll give you the details of looked at an intranasal H5 influenza vaccine, and it includes adjuvant as a way to try to improve the antibody response and to block the pandemic influenza. Last fever vaccine started. This was a phase 1 study, started in Liberia. It's a collaboration called Prevail, which is a collaboration between the NIAID and the Liberian Ministry of Health. And then this particular study was done in additional collaborations with IAVI and CEPI. But it's a novel Lassa vaccine, and we worry about Lassa fever outbreaks and the potential for broad disease from that. So I think this study is a significant advancement. We are doing studies in monkeypox. We are doing additional intradermal studies to verify and look again at the intradermal dosing, the 2 × 10⁷ and the subcutaneous dosing. And then we're also looking at a lower intradermal dosing, and we'll look at both vaccinia neutralizing responses and monkeypox virus-specific neutralizing responses. So we think that will add considerable data to the use of intradermal vaccines for monkeypox. Lastly, there's a Nipah vaccine study that started at the NIH. This is based off an mRNA platform and is done in collaboration with Moderna. Nipah is also one of the diseases we worry about the pandemic potential, and having an immunogenic vaccine is going to be the first step towards doing studies to see if we can have a new vaccine in the armamentarium for Nipah. That concludes the updates from the National Institute of Health. Thank you.
Thank you, Dr. Weigel. Next, we'll move on to the Office of Infectious Disease and HIV/AIDS Policy.
Well, good morning. This is David Kim with the Office of the Infectious Disease and HIV/AIDS Policy and the Office of the Assistant Secretary for Health. The National Vaccine Advisory Committee met on September 22 and 23. At the meeting, as Dr. Duchin, who's a member of NVAC, mentioned yesterday, the committee approved the report with 25 recommendations to sustain and increase confidence in vaccines across the lifespan. The report will be made available on the NVAC website, and the next NVAC meeting will be on February 2 and 3 in 2023. Healthy People 2030 seeks to establish a national prevention agenda with evidence-based measurable targets to be achieved by the end of the decade. The OIDP National Vaccine Program is working with the HHS Office of Disease Prevention and Health Promotion and CDC to formalize 2 immunization objectives as a part of the HP 2030 Immunization and Infectious Diseases core objectives. And the first of this is to increase the proportion of people who receive Tdap during pregnancy. And the second is to increase the proportion of adults aged 19 years or older who have received recommended age-appropriate vaccines. As a reminder of its importance, in Healthy People 2030, the annual flu vaccination objective is one of 10 leading health indicators for all ages. Of course, the flu season is now upon us. HHS supports efforts to prevent the flu with the campaign Flu to the Flu to drive home the message for people to get the flu vaccine by the end of October. HHS has also recently launched several audience-specific digital media toolkits on hhs.gov/immunizations to promote the flu vaccine in racial and ethnic minority populations and for the first time, small businesses. And then lastly, now available on hiv.gov is a video series featuring the OIDP Director, Tay Hayes, and the White House National Monkeypox Response Deputy Coordinator, Dr. Dimitri Daskalakis of CDC. In the videos, the importance of equity and wellness, federal monkeypox response, and monkeypox vaccine efficacy and vaccine availability are discussed. And that concludes my remarks for the Office of Infectious Disease and HIV/AIDS Policy. Thank you.
Thank you, Dr. Kim. And with that, our agency updates have concluded. So now I'm going to launch into our first session for today. And as a reminder, we're going to finish up our business from yesterday regarding the votes for the pneumococcal vaccine. Dr. Kobayashi will first provide an overview to address some of the questions raised by the committee yesterday, and then we will review the motions on the table one at a time. So Dr. Kobayashi, please go ahead.
Thank you and good morning. So previously, PCV13 was recommended for high-risk adults, and in 2021, ACIP recommended use of PCV15 or PCV20 for certain high-risk adults who have not previously received PCV or whose previous vaccination history is unknown. So adults who receive PCV13 are currently recommended to complete the series with PPSV23. We know that conjugate vaccines have immunologic advantages over polysaccharide vaccines, and PCV20 currently provides the broadest serotype coverage among available conjugate vaccines. Okay. So the proposed recommendations address two questions from the current recommendations. One, should we add PCV20 as an option to PPSV23 for adults who received PCV13 but have not completed their series? And two, should we add PCV20 for adults 65 and older who completed their series with both PCV13 and PPSV23 for added protection? In the next few slides, I will walk through these in more detail. Next slide, please. So this shows the current recommendation. Use of PCV20 alone or PCV15 in series with PPSV23 is recommended for high-risk adults who have not previously received PCV or whose previous vaccination history is unknown. So this includes adults 65 and older and younger adults with certain risk conditions. And adults who have not received any pneumococcal vaccination are not recommended to receive PCV13 anymore under the current recommendations. Next slide. For adults who started their series with PCV13 before the update, these adults are currently recommended to complete the series with PPSV23. So in the next few slides, I will go over each of the three groups we are considering and how the proposed recommendations look like. Next slide. So please note that we changed the order of the groups from yesterday. So now group 1 is adults with an immunocompromising condition, cochlear implant, or CSF leak, who received PCV13 and PPSV23, but have not completed their recommended series. The estimated size of this group is 0.2 million based on vaccine coverage data. And the intent is to add an option of PCV20 for pneumococcal vaccine series completion. Next slide. So this is how the updated recommendation will look like. There will be an option to complete the series with PCV20, which is shown as the green box. Next slide. So the second group are adults 65 and older who received both PCV13 and PPSV23. So these adults are currently have completed their series under current recommendations, and the estimated population size is 17 million, again based on vaccine coverage data. Next slide. And so the proposed policy option is whether or not to add another dose of PCV20 to these adults who have currently completed the recommended series. Next slide. So the final group, group 3, are adults who started the series with PCV13 under the previous recommendation, but have not received PPV yet. Next slide, please. And I forgot to mention the estimated population size is 0.2 million could you go back to the previous slide, please? Sorry, so for 19 to 64 years, the estimated population size is 0.2 million, and then for adults 65 and older, the estimated population size is 9 million. Next slide, please. So the new policy option is to add an option of PCV20 for pneumococcal conjugate vaccine series. So this is the end of my additional presentation. Thank you.
Thank you, Dr. Kobayashi. So since we spent a significant amount of time in discussion yesterday about the pneumococcal votes, I'm just going to ask the committee to keep our discussion focused on clarifying questions regarding what Dr. Kobayashi just presented or any new key issues that will impact the decisions in front of us. So actually, Dr. Kobayashi, if you could please go to the first motion you'd like to present today.
Okay, thank you. Next slide, please. Could you go to the policy language, please?
But are there any clarifying questions our members might have? Dr. Cotton.
Could you just go to the immunocompromised? So for the slide with the immunocompromised. So it would be PCV13 plus PCV20, but nothing after 5 years.
Correct.
Even though we know immunity wanes significantly in that population.
So currently, no, and then this is just to try to be as consistent as possible as the current recommendation. And could you please go to slide 2, please? 2. So actually, I wanted to highlight that currently adults who are immunocompromised and have chronic medical conditions, they are recommended to receive 1 dose of PCV20. And then as of now, we don't have repeat vaccine recommendations for this group. And in part, this is because there are some uncertainties about how the future would look like. We have new higher valency pneumococcal vaccines in advanced stages of development. We know that PCV20, we anticipate that PCV20 will be used in children in the near future. So it's possible that we will be revisiting these recommendations.
Thank you.
Any additional clarifying questions? Dr. Talbot.
No, you're fine. The only question I have is why wait 5 years for the PCV20 if we can give them better protection? I don't understand why we're waiting. Oh, yeah, I can. I've never been told I'm too quiet. I don't understand why we're waiting 5 years for PCV20 because it seems like these are a high-risk population and they would benefit to getting this at, about 1 year after getting the previous vaccine.
So thank you for your question. So this was based on understanding of the current duration protection of these vaccines, plus also the economic analysis to understand, when would be the timing that would maximize protection, but would also make sense from the economic perspective.
Dr. Paling.
The third reason was a strong sense from the practicing clinicians that it was important that you have the same time frame and that you don't use a different time frame if you're using one vaccine than the other, and to try to simplify and use the same time frame for whichever vaccine you're using.
All right, can we please go back to the first motion that Dr. Kobayashi would like to discuss? These are in slightly different order from yesterday. Go ahead, Dr. Kobayashi.
So this is what I presented yesterday. And so for adults with an immunocompromising condition, cochlear implant, or cerebral spinal fluid leak who have received both PCV13 and PPSV23 before age 65 years with incomplete vaccination status are recommended to receive a dose of PCV20 at least 5 years after the last pneumococcal vaccine dose, or PPSV23 as previously recommended, to complete their pneumococcal vaccine series.
And this motion is still on the table. Any questions about this particular motion? Any additional comments? Okay, I don't see, Dr. Long.
I would think it would be clear if this is not a change, but not saying before 65, because then it seems that the interpretation is when you get to be 65, you need something else. And I'm wondering what, I would think that should say 19 to 64, 18 to 64, or whatever.
Could you go to the next slide, please? So
you know, even a clearer way to say that would be so everybody gets who these people are, who are more than 5 years out from their PPSV 23 and haven't yet received such. I think then everybody would know who exactly these people are, because that's the only reason they're not really incomplete. They are needing the booster if they're more than 5 years out.
Dr. Talbot?
Am I
Actually,
missing
so
something?
I think what you're just saying, Dr. Long, to me looks consistent with the recommendation or the vote language that is on the table. If we need to add clarifications, I think we can defer to the work group to make sure that the intent is as clear as possible. But I do want to make sure we can move forward with the vote language if there is no substantial differences in terms of what the vote should be.
I'd like to propose an amendment. I'd like to propose that it's 1 year, because I don't know why we're using polysaccharide at all in an immunocompromised group.
So you're making a motion?
I'm making a motion to do an amendment. Thank you.
Is there anybody who would like to second the motion?
I would like to second that motion.
Okay, Dr. Cotton has decided to second the motion. So we now have an amendment on the table that's been moved and seconded. So Dr. Long, did you have an additional comment?
I would. You know, we looked at this very carefully in the work group. And if one has received both a conjugate vaccine and a PPSV 23, they really are pretty well protected for 5 years, so that it really adds very little to give them another vaccine right after that. It's not as if they're just getting PPSV 23, but PPSV 23 after PCV 13 is pretty good. It's just not sustainable over 10 years.
Dr. Paley?
Can I ask a clarifying question? I assume that's based on serologic data, not clinical data, so we don't actually know about protection?
Dr. Kobayashi?
One thing that may help, when we did the cost effectiveness analysis, we did assume lower vaccine effectiveness specifically for the immunocompromised conditions. And I don't know if that information helps, but just wanted to share that to try to reflect the possible differences in the clinical protection in these adults, high-risk adults.
Dr. Paling?
One of the perspectives that I'd like to share from the work group is that not only do the infectious disease physicians need to be treating and vaccinating the immunocompromised, but your primary care physicians need to be doing that. And so one of the important principles that we've used to guide the work group is simplifying the recommendations. And so the perspective that was shared from the treating physicians is if you could use the same regimen for the same groups, that would enhance coverage, because we know the coverage in this group is very low. Thank you.
Yeah, thank you. I'm also going to endorse staying consistent with the current recommendations, in part because I just think if we start to change this for this small group, it's going to get really confusing for most clinicians. So while I understand the point made, I feel like we have to make it easier for people to just use this as an opportunity. Dr. Cotton.
I'd like to emphasize that approximately 3% of the U.S. population is immunocompromised, and as we showed in the presenting slides, 9 to 18 times at greater risk for invasive pneumococcal disease. Many of these decision-making analyses are run by computer with alerts. And so I think in the era of many people using electronic medical records, that could be of assistance. So I don't know that we need to make a decision that is likely to be less protective to a highly vulnerable population just to make one size fits all.
I think we should put it to a vote. So let's plan to proceed. To the voting members, I'm going to actually ask you to state your name, whether you have any conflicts of interest, and your vote. And I'm going to start with Dr. Daly.
Excuse me, sorry, this is Dr. Bell. Could you clarify, are we voting on the amendment or are we voting on the wording that's in front of us on the slide?
Actually, we are voting on the amendment before we can go back to the motion. And the amendment is to change this language to say at least 1 year after the last pneumococcal vaccine dose. So it is not exactly what's up there. And if our team here can just change it to 1, at least right here for the moment, so we can make sure that everybody is voting on the same issue. Thank you, Dr. Bell.
Point of order, Madam Chair. If we're voting, should we have our camera on?
And thank you. We need our cameras on.
Why is my mouse acting up? Come on, Mr. Mouse.
Okay, Dr. Daly.
Daily, no conflicts, no.
Dr. Brooks.
Brooks, no conflicts, no.
Ms. Bata.
Bata, no conflicts, no.
Dr. Lair.
Lair, no conflicts, no.
Dr. Chen.
Chen, no conflicts, no.
Talbot.
Talbot, no conflicts, yes.
Dr. Paling.
Paling, no conflict, no.
Dr. Sineas.
Sineas, no conflict, no.
Dr. Cotton. Oh, okay. We will move on to Dr. Long.
No conflict, no.
Dr. Shaw.
Shaw, no conflicts, no.
Dr. Sanchez.
Sanchez, no conflict, no.
Dr. Bell.
Bell, no conflicts, no.
Ms. McNally.
McNally, no conflicts, no.
Dr. Cotton.
Cotton, no conflicts, yes.
Thank you. Dr. Wharton. What is the count? Oh, I have to vote. Thank you. Oh my gosh, I need everybody at this table today. Lee, no conflicts, no.
Thank you. The vote on the amendment did not pass. There were 2 votes yes and 13 votes no.
Thank you, Dr. Wharton. This amendment to the motion does not pass. We will move back to the original motion. Oh, thank you. You already put up the 5 years. So the original motion is up on the slide. Any quick questions? Okay, I'm going to move forward, and I'm going to call on Dr. Shaw first. Name, conflicts of interest, and your vote.
Shaw, no conflicts, yes.
Dr. Long?
Long, no conflict, yes.
Dr. Cotton?
Cotton, no conflicts, no.
Dr. Sineas?
Sineas, no conflict, yes.
Dr. Paling?
Paling, no conflict, yes.
Lee, no conflicts, yes. Dr. Talbot?
Talbot, no conflicts, yes.
Dr. Chen?
Chen, no conflicts, yes.
Dr. Lair?
Lair, no conflicts, yes.
Ms. Bata?
Bata, no conflicts, yes.
Dr. Brooks?
Brooks, no conflicts, yes.
Dr. Daly?
And Daily, no conflicts, yes.
Ms. McNally?
McNally, no conflicts, yes.
Dr. Bell?
Bell, no conflicts, yes.
Dr. Sanchez?
Sanchez, no conflict, yes.
And the motion passed 14-1.
Thank you. Thank you to my committee members. We will now move on to the second motion. I should just have stated that that vote did pass. We'll move on to the second vote. Dr. Kobayashi, vote language for the second motion on the table. Please go ahead.
Shared clinical decision-making is recommended regarding administration of PCV20 for adults aged 65 years and older who completed their vaccine series with both PCV13 and PPSV23. If a decision to administer PCV20 is made, a dose of PCV20 is recommended at least 5 years after the last pneumococcal vaccine dose.
I see Dr. Talbot's hand is raised. Dr. Talbot.
I want a motion, that's the word, to do an amendment to this, to make it, we recommend and not do shared clinical decision-making. I'd also like to do it for 1 year, but I won't even try. So just to change this from shared clinical decision-making to recommended.
Sorry, do we have a second?
I second that.
Okay, Dr. Cotton.
Along with the full remarks of Dr. Talbot.
Okay, thank you. Thank you, Dr. Cotton and Dr. Talbot. So it's been moved and seconded that we amend this current motion from shared clinical decision-making to a recommendation. A full recommendation. Okay. Dr. Long, you have a question?
Are we discussing?
Please go ahead. If you have any questions about it, please do.
Yes.
And we have the amendment on the table right now.
Yeah, discuss the amendment and then vote on the amendment. Dr. Kobayashi maybe should come back. I wonder if you, Dr. Kobayashi, or you, Dr. Paling, can tell us again the effect in numbers and dollars of this if we made this amendment.
I'm sorry, so the question was the economic analysis?
If we make this a recommendation rather than shared decision-making, can you remind us what's the number in this population and remind us one more time what the cost effectiveness was per quality?
Yeah, so the cost per quality, so it really depended on the model that we looked at. So the one that was in the middle of the three models was the estimate by Merck, which was around like 227,000. But then the CDC model ranged, and depending on the assumptions that we used, the higher range was about like 440,000 per quality gained. And the lowest estimate was the one from Pfizer, excuse me.
And Milwaukee, am I correct, this impacts about 17 million adults over the age of 65?
So the size of the population, that is correct. It is about 17 million based on vaccine coverage data.
Thank you. Dr. Bell?
Thank you. I just wanted to voice my opinion that I'm not going to support this amendment. I think while we all want to quote to sort of save as much lives as possible, we do have to, in my opinion, I also feel like I have to look at the big picture. This is a change which has a small incremental benefit. The idea of boosting, essentially revaccinating with a new vaccine that provides small incremental benefit for a very large population is just not, I don't think, prudent. And I do have, while I don't make my decisions based only on cost effectiveness, I don't feel like it's a good idea to endorse something which involves, as I say, essentially revaccinating a very large number of people for a very small incremental benefit. I don't love this shared clinical decision-making as a way to communicate an idea that this is something that, could be done, but we don't have a better way to do it. I think this population, being a member of this group myself, is a very heterogeneous population. And there may be some people who, don't feel like it's worth it to get another dose of vaccine, and other people where it might really be very important, and this provides this as an option. So I think that there are other considerations besides providing even, the most possible benefit. And I don't think revaccinating with an updated vaccine of a very large number of people in this circumstance is warranted, in my opinion.
Thank you, Dr. Bell. Dr. Talbot.
So quickly, I just want to remind everyone that those cost effectiveness analyses greatly underestimated the impact on both the children of older adults and older adults. Two, I also want to remind everyone at 5 years, the polysaccharide vaccine is waned. It's waned. It's gone. It's a B-cell vaccine, and 5 years later, it's not good. And so this is not only boosting to improve the polysaccharide, but also gives them extra protection. So I really don't think this is just an incremental benefit. It's a huge benefit. And many older adults are still working, and some of them are at the table with us, and we would like to keep them working because they have brilliant minds and should be able to continue to contribute.
Thank you. Dr. Brooks?
Yeah, it's a dilemma. The cost effectiveness data is compelling. It's the largest population we're discussing. But I also remember the data yesterday that the higher rate of pneumococcal disease in African Americans with those types that are not in PCV13 is a concern. And then I also think when it becomes shared decision-making, that concept will not necessarily serve that particular population well. So I can see both sides of it, but I lean more toward what Dr. Talbot said and my impression of what communities and what population will be mostly served by this additional vaccine.
Ms. McNally.
Dr. Lee, I wonder if we might hear from the American Geriatric Society and any other liaisons who are interested in weighing in on this issue. Thank you.
Dr. Schmader, are you on the line?
I am. And as I stated yesterday, I fully support Dr. Talbot's position. The AGS believes that shared decision-making is simply not pragmatic. And all the other arguments Dr. Talbot made, we agree with.
Any other comments?
If I may, Dr. Grace, Dr. Lee.
Actually, I think we're going to, Dr. Goldman, we are almost at time. I'm not sure we're going to get through the 3 votes. I'm going to limit it to voting members for this discussion. My apologies.
Okay, just if I may, I did ask for input. If Dr. Goldman may be able to reply.
Okay. Dr. Goldman, if you can be extremely brief.
Extremely brief. I absolutely support Dr. Talbot's suggestion. I also support 1 year. As a practicing physician, I think it's extremely important to not look just at the cost effectiveness, but the effect on the individual. And so I absolutely support making this a strong recommendation.
Thank you. I'll just add my 2 cents that, I think this committee not only deliberates on the recommendations themselves, but also has a fiscal responsibility. So we just have to be aware of the fact that we are tied to both insurance requirements as well as, the Vaccines for Children's program. Obviously, this is targeting the older adult population, but it does have impact. So on Medicare, thank you. All right. I don't see any additional hands raised. Dr. Kobayashi, did you want to add anything? Okay. Let's put a vote to this proposed amendment that is listed on the slide. Thank you for your help. And I'm going to actually start with, let's see, I'm going to start with Dr. Saneas. Dr. Saneas.
Saneas, no conflict, yes.
Oh, if everybody, I think we have cameras on still. No? If you don't have your camera on. Okay, Dr. Paling?
Paling, no conflict, no.
Lee, no conflict, no.
Talbot, no conflict, yes.
Dr. Chen?
Chen, no conflict, yes.
Dr. Lair?
Lair, no conflicts, no.
Ms. Bata?
Bata, no conflict, no.
Dr. Brooks?
Brooks, no conflicts, yes.
Dr. Daly?
Daily, no conflicts, no.
Dr. Bell?
Bell, no conflicts, no.
Ms. McNally?
McNally, no conflicts, yes.
Dr. Sanchez.
Sanchez, no conflict, no.
Dr. Shaw.
Shaw, no conflicts, yes.
Dr. Long.
Long, no conflict, no.
Dr. Cotton.
Cotton, no conflicts, no.
I'm going to give her a moment to tally this because I couldn't count in my head.
The motion for the amendment did not pass. The vote was 6-9.
6 yeses, 9 noes. The amendment does not pass. So we will return to the original motion that was on the table for shared clinical decision-making. And we will unmark those now. I'm hoping, any other important comments? Okay, we're going to move forward because Dr. Wharton's bell just rang. And I'm going to just, while we're waiting for the wording to be changed, I'm just going to warn my committee members that we are going to have an abbreviated lunch today and probably some shorter breaks. So my apologies in advance. And we are going to try and keep this meeting on time as much as possible. Thank you. So we have the original motion back on the table. I'm going to start this time to my right and ask Ms. Bata if you would be willing to vote first.
Bata, no conflict, yes.
Dr. Brooks?
Brooks, no conflicts, yes.
Dr. Daly?
Daily, no conflicts, yes.
Dr. Bell?
Bell, no conflicts, yes.
Ms. McNally?
McNally, no conflicts, yes.
Dr. Sanchez?
Sanchez, no conflict, yes.
Dr. Shaw?
Shaw, no conflicts, yes.
Dr. Long?
Long, no conflict, yes.
Dr. Cotton?
Cotton, no conflicts, no.
Dr. Sineas?
Sineas, no conflicts, yes.
Dr. Paling?
Paling, no conflict, yes.
Lee, no conflicts, yes. Dr. Talbot?
Talbot, no conflicts, yes.
Dr. Chen?
Chen, no conflicts, yes.
Dr. Lair?
Lair, no conflicts, no.
Okay. I'll defer to Dr. Wharton on the count again.
The motion passed, 13 yes, 2 no.
Thank you. So the second motion passes. We are going to move on to the third, and I'm going to ask people to keep comments extremely brief if there are any. Dr. Kobayashi, could you please read the current motion?
Yes. Adults who have received PCV13 only are recommended to receive a dose of PCV20 at least 1 year after the PCV13 dose, or PPSV23 as previously recommended to complete their pneumococcal vaccine series.
Okay. I don't see any member hands. Okay, Dr. Long.
I propose we accept.
Okay. Motion is on the table, so I think we can move to a vote if there's no additional objections to moving to a vote. Okay.
I would just say in the clarifying language for that, that you would need to say that if 5 years passes after PPSV 23, they may need another dose of something. These are presumably people who got 13 for a reason.
I'm going to ask that if our members will allow that we will take this motion on the table. If there's additional discussion that needs to be had, I'm going to actually bring it back. Ask Dr. Kobayashi and Dr. Paling to take it back to the work group. Okay. All right. Well, Dr. Long, since you raised your hand, I'm going to ask you if you'd be willing to put forward the first vote.
Absolutely. Long. No conflict, yes.
Cotton, no
Cotton.
conflict, yes.
Dr. Sineas.
Sineas, no conflict, yes.
Dr. Paling.
Paling, no conflict, yes.
Lee, no conflicts, yes. Dr. Talbot.
Talbot, no conflicts, yes.
Dr. Chen.
Chen, no conflict, yes.
Dr. Lair.
Lair, no conflicts, yes.
Ms. Bata.
Bata, no conflict, yes.
Dr. Brooks.
Brooks, no conflicts, yes.
Dr. Daly.
Daily, no conflicts, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Bell.
Bell, no conflicts, yes.
No, okay. Dr. Sanchez.
Sanchez, no conflict, yes.
Dr. Shaw.
Shaw, no conflicts, yes.
And the motion passes unanimously, 15-0.
Thank you, everyone, for your work today. Appreciate it. And Dr. Freihofer, my apologies. Did you want to make a very brief comment?
Yeah, so this is just Sandra Freihofer, American Medical Association, speaking as a practicing physician who administers vaccines in my office. A clarifying question. In the first vote, it said PPSV 23 is previously recommended. Could you add the 5? I think in the first vote it was 5 years, and now in this one it's 1 year. So that kind of clarifying language would be helpful for practitioners because there have been.
Yeah,
we don't know.
Thank you, Dr.
recommend-
Freihofer. We really appreciate the clarifications to help our frontline providers. Dr. Kobayashi will take that back to the CDC team, and we will make sure that that is incorporated in some way in the MMWR statement. And with that, we will move on to our original first session for the morning, which will be on combined immunization schedules. And it looks like Dr. Sineas, who is chair of this who is chair of this work group, will provide an introduction and overview. Dr. Sineas.
Thank you, Dr. Lee. Next slide. The Combined Immunization Schedule Work Group updates the child and adolescent and adult immunization schedules annually. The Child Adolescent Immunization Schedule summarizes ACIP's vaccination recommendations for persons 18 years of age or younger, and the Adult Immunization Schedule summarizes ACIP's vaccination recommendations for persons 19 years or older. The goal of the Combined Immunization Schedule Work Group is to better harmonize the child, adolescent, and adult schedules. No new policy is established by the schedule, rather it reflects a summary of ACIP recommendations. Next slide. The working group includes 3 ACIP members, myself and Dr. Alt as our outgoing chair, and Veronica McNally. I would like to acknowledge our liaison representatives listed here, our work group consultants, ex officio members, and consultants, and the leadership of our CDC co-leads, Dr. Patricia Woody and Dr. Neil Murthy. Next slide. We wanted to take a moment to thank Dr. Kevin Alt, the outgoing chair, for his leadership over the last 4 years. Next slide. I must also acknowledge all the CDC subject matter experts listed here that contribute to the work group activities. Next slide. I would like to remind the committee and the audience why we present the schedule for vote every fall. ACIP's approval is necessary prior to publication of the schedule in February of the following year. In addition, ACIP approval is necessary before we have our partners from the professional organizations listed here to review and approve the schedule. Of note, this is the first year that the American Pharmacists Association will be listed as an approving organization for the adult schedule. We welcome them and their input. Next slide. Presentations on revisions to both schedules may include the use of vaccine trade names. This is for identification purposes only and does not imply endorsement by the CDC. The proposed edits that will be discussed are subject to change based on ACIP's discussion and vote. Next slide. For the remainder of this presentation, Dr. Woody will discuss the proposed edits for the child and adolescent schedule, and Dr. Murthy will discuss the proposed edits for the 2023 adult immunization schedule. These edits are intended to incorporate ACIP recommendations and MMWR publications that have occurred since November of 2021, and improve readability and utility of the schedule into language that is easy to interpret for the busy provider. In addition to the harmonization for both schedules, there are proposed edits to the tables, content changes in the notes section, and changes to the appendix listing the contraindications and precautions for each vaccine type. This session will conclude with discussion of the proposed edits, followed by a vote on the adult schedule and child and adolescent schedule. I will now ask Dr. Woody to take us through the proposed edits in the child and adolescent schedule. Thank you.
Thank you. Please go ahead, Dr. Woody. Thank you.
Thank you, Dr. Seniors. My name is Dr. Woody, and I'll present the proposed edits for the 2023 child and adolescent schedule. This is an outline of my presentation today. First, I will present changes to the tables, then the vaccination notes, and then I'll finish with the proposed edits to the appendix. Beginning with the cover page, in the table of vaccine abbreviations and trade names, we are proposing 3 edits. The first edit is to add COVID-19 vaccines, and we've used separate abbreviations for the monovalent and bivalent mRNA vaccines. We also have a separate abbreviation for the monovalent protein subunit vaccine. In the measles, mumps, and rubella vaccine role, we've added Priorix, and in the pneumococcal conjugate vaccine role, we've added PCV15. Our table 1 is the routine immunization schedule by age. In table 1, we have added a role for COVID-19 vaccines, and we've shaded age 6 months through 18 years in yellow, indicating the recommended age for vaccination. We have also included an overlying text prompting providers to review the notes section for more details on the primary and booster vaccination. In the pneumococcal vaccination role, we have added PCV15. And in the inactivated poliovirus vaccine role, for age 18 years, we've added C notes, prompting providers to look at the notes section for more details. Table 2 is the catch-up immunization schedule for children who have started late or are more than 1 month behind. We have 1 proposed edit for Table 2. In the pneumococcal conjugate role, for the minimum interval between those 3 and 4, we have revised the text to indicate when the 4th dose is recommended. Table 3 is the immunization schedule by medical indication. In Table 3, we have added a role for COVID-19 vaccine, and in the columns for HIV infection and immunocompromised status, excluding HIV, we've added the overlying text C notes. Next, I'll present the edits to the notes section. Under additional information, in the bullet for injury compensation, we've added COVID-19 vaccines, and we've added a sentence stating that COVID-19 vaccines that are authorized or approved by the FDA are covered by the Countermeasures Injury Compensation Program, and we've included a link to the webpage for the program. We've deleted the previous COVID-19 vaccination box, and we've added a new section for COVID-19 vaccination. We use the format, the age-based format in the infographics present on the CDC webpage for use of the COVID-19 vaccines. The routine vaccination section summarizes the recommendations for children and adolescents who are not moderately or severely immunocompromised. For the primary series section, based on the age of the child, we've included the dose series and the recommended interval between doses for each product. Because booster dose recommendations are still evolving, we've included a link to the webpage with the most current recommendations. In the special situations section, we've summarized the recommendations for children and adolescents who are moderately or severely immunocompromised. And for the primary series, we've included the dose series and the recommended minimum interval for each product. For booster vaccination, we've included the link to the web page. We also added a bullet reminding providers that pre-exposure prophylaxis may be considered to complement COVID-19 vaccination in this population. And then at the end, we've added a note reminding providers that an age-appropriate vaccine product should be administered for each dose. We've included links to the current COVID-19 schedule and the dosage formulations. And we also have a link to where the emergency use authorizations are located. Now, moving on to dengue vaccination, we have a new bullet stating that dengue vaccine should not be administered to children traveling to or visiting endemic dengue areas. And for hepatitis B vaccination, there are no new recommendations, but we've reorganized the section so that healthcare providers can easily find recommendations based on the mother's hepatitis B surface antigen status. So we have a section for children whose mothers are hepatitis B surface antigen positive. Okay, and then we have another section for children whose mother's hepatitis B surface antigen status is unknown. We also included information reminding providers that if, for these infants, if the mothers have evidence suggestive of hepatitis B infection, the infant should be managed as if the mother is hepatitis B surface antigen positive. In the catch-up vaccination for hepatitis B, we've added Heplicef B and Prehebrio as options for adolescents aged 18 years and older. For influenza vaccination, we added back the recommendations for persons with egg allergy with symptoms other than hives. Last year, this information was in the appendix as a precaution, but we realized it's not a precaution, and we brought it back to this section. We have a new bullet in the special situations section stating that LAIV4 should not be given to close contacts of severely immunosuppressed persons who require a protective environment. In the MMR vaccination notes, we have a new bullet in the special situations section addressing the use of additional doses in a month outbreak setting. For meningococcal ACWY, we've included information on the newly licensed one-vial liquid formulation of Menveo. So we have that Menveo now has two formulations, the one vial all liquid and the previous two vial formulation. The Menveo one vial formulation should not be used before age 10 years. And in the MenB vaccination notes, we have, in the special situations section, we have just harmonized this with the adult schedule, where we added the language in parentheses for if dose 2 is administered at least 6 months after dose 1, or dose 3 is administered earlier than 4 months after dose 2. In the pneumococcal vaccination notes, we've added PCV15, which was approved for children and adolescents in June. We've replaced PCV13 with PCV in all the sections. We've added a note stating that PCV13 and PCV15 can be used interchangeably for children who are healthy or have underlying conditions. No additional PCV15 is indicated for children who have received 4 doses of PCV13 or another age-appropriate complete PCV13 series. We have deleted the chronic liver disease and alcoholism bullets because those are not risk factors for invasive pneumococcal disease in children and adolescents. And then in the polio vaccination note, we've added a new special situation section to address adolescents age 18 years at increased risk of exposure to poliovirus. Those in this age group who do not have evidence of a complete polio vaccination series, which is defined as at least 3 doses, should get the remaining doses to complete a 3-dose series. And those who have evidence of having at least 3 doses may receive a 1 lifetime IPV booster. We've included the link to a web page the CDC created with more details on this information. Lastly, I will go over the proposed edits for the appendix. The appendix was added last year, and it lists the contraindications and precautions for the vaccines in the schedule. We changed the header from contraindications to contraindicated or not recommended. In the hepatitis B role, we've added a new bullet stating that Heplisav and Prehebrio are not recommended during pregnancy due to lack of safety data in pregnant women. Healthcare providers are advised to use other hepatitis B vaccines if indicated. In the footnote, we've added links to the pregnancy registries for both vaccines. In the HPV rule, we've added a new bullet stating that HPV vaccination is not recommended during pregnancy. And in the MMR rule, we've added MMRV vaccine product. And in the precautions column, we've added a new bullet saying that personal or family history of seizure of any etiology is a precaution for using MMRV. And then in the varicella rule, in the precautions column, we've added a new bullet saying that if healthcare providers are going to use MMRV, they should see the MMR rule for additional precautions. And that's the end of my updates. I'll now take questions. Thank you.
Presentation is now open for questions. Ms. Bata?
Just a point of clarification. I know that we have already recommended COVID-19 for children, but it's under an EUA. Is it okay for us to include that in the routinely recommended schedule if it's a EUA interim recommendation?
Yeah, before we brought this to the work group, we had a conversation about this with our Office of General Counsel, and we're told that it was okay to add it to the schedule.
Dr. Brooks.
Can you go to the one on polio? It was
Polio?
age 18, about 5 slides back or so. 39? Thanks, Jamie.
This one, yeah.
Yeah, it says adolescents age 18 years, so is it only for an 18-year-old, not a 17 or a 19-year-old?
It's only, the current polio policy has a routine recommendation up to age 17 years. So beginning at age 18 years, the routine vaccination is not recommended, and this policy is from 2000. So for persons who are age 18 years and older, polio vaccine is recommended if they are at increased risk of exposure. So in the child and adolescent schedule, which is up to 18 years, this only applies to adolescents age 18 years, and those 19 years and older will be reflected in the adult schedule.
Okay, thank you for the clarification.
Any additional questions? Actually, I have one question on slide 37. When you replacing for the pneumococcal conjugate vaccines, my simple question is, why did we delete chronic liver disease? Is that no longer a risk factor for anybody?
Miwako can help me here, but my understanding is that it was, in the last policy note, it was added in error for the children and adolescents, and when the new policy note for use of PCV15 was written, that error was corrected. She's asking why we deleted chronic liver disease and alcoholism from the child and adolescent schedule. Miwako?
Just for clarification, I think alcoholism makes sense. I think chronic liver disease, we definitely see children with chronic liver disease who need liver transplants. So
So yes, thank you for that question. So what happened in the past was chronic liver disease was never part of the table that lists the risk conditions for the pediatric table, and then that's reflected in the current MMWR R&R that was published in 2010. And when there was a vote on use of PCV13 in children with underlying conditions, immunocompromised conditions, age 6 to 18 years, and that was back in 2013. When the MMWR was published, the table that was included in the published MMWR was reflected the conditions that's used in the adult group. So there's always been this confusion because it was never the intent to change the table. It was not something that was presented to ACIP, but then when the MMWR was published, the table for that age group was switched over. So with the update, with the recent MMWR that was published for the PCV15 recommendation, we tried to just address that previous confusion that happened.
And maybe I'll just ask if the pneumococcal work group will consider that in the future.
I would like to clarify, we're going to be addressing PCV20, and this would be a very easy way to include that in that conversation.
Thank you so much. Any other clarifying questions? Oh, Dr. Daly.
Yeah, so I'd like to make a couple sort of overarching comments, and this is in response to public comment that we've received. So is that okay, Dr. Lee? Do we have time for that? Okay. So, you know, we've received comments from the public that are concerned about adding COVID-19 to the routine schedule, to the routine childhood schedule, and I just want to address that directly. You know, this doesn't represent new recommendations. This represents sort of a summary of existing recommendations. But I will acknowledge, I appreciate that there is symbolism in adding COVID-19 to the childhood immunization schedule. And that symbolism is that we view this as routine and that we view this as COVID is here to stay. And so when I think about the routine immunization schedule as a practicing pediatrician, I think about it as an opportunity in my patients to prevent serious disease and death. That's what I view that as. And if something is added to the schedule, it's because I feel like the benefits continue to strongly outweigh the risks. And so I just want to make those points. The other point I will make is that this does not constitute a mandate, but there are mandates, but those are really state Board of Health largely decisions, and this doesn't represent a mandate. But then I appreciate that if parents are concerned about COVID-19 vaccines, then they're concerned that this could be turned into a mandate. And again, I would want to turn that conversation in a different direction. I've had parents who've come in my office and I say, oh, what are you here for? And they say, well, we're here for vaccines so that our kids can go to school. And I've said, okay, I understand that, but really I'm not vaccinating so you can go to school. I'm vaccinating because I want to prevent serious disease and death in your kids. And the fact that there's a school immunization requirement helps because it brought you into the office, but that's not my goal. My goal is to prevent serious disease. So those are overarching comments. I just want to acknowledge that we heard the public's concern about this in the public comments, but just to reiterate that the reason things are added to the schedule is that we feel like the benefits strongly outweigh the risks, and these are opportunities for disease prevention, but we acknowledge that there's concern on the part of the parents. I guess the last point I'll make is we just need to continue to do better at communicating why we think the benefits strongly outweigh the risks. Thank you.
Thank you, Dr. Daly. I don't see any additional hands raised. Oh, Dr. Shah, please go ahead.
I'd like to underscore the importance of Dr. Daly's comments, and I wanted to add one or two other pieces of clarification. The vote and the discussion around the addition of COVID-19 vaccines to the recommended immunization schedule is separate and distinct from yesterday's vote in support of a resolution to add COVID-19 to the Vaccines for Children program schedule at the point that the vaccines become commercialized. Yesterday's vote, in effect, was a resolution about the coverage of the vaccine for and underinsured children, not a discussion of what pediatricians ought to be doing in an office setting. This discussion today around adding the COVID-19 vaccine to the recommended childhood immunization schedule does not constitute a requirement that any child receive the vaccine. That decision remains where it did before. This is rather a codification of a pre-existing recommendation. We recognize that there is concern around this, but moving COVID-19 to the recommended immunization schedule does not impact what vaccines are required for school entrance, if any. Indeed, there are vaccines that are on the schedule right now that are not required for school attendance in many jurisdictions, such as seasonal influenza. Local control matters, and we honor that. The decision around school entrance for vaccines rests where it did before, which is with the state level, the county level, and at the municipal level, if it exists at all. They are the arbiters of what vaccines are required, if any, for school entry. This discussion does not change that. Thank you.
Thank you, Dr. Shah. And with those comments, I think what I'd like to do is move on to the next session by Dr. Neil Murthy on the 2023 adult schedule revisions.
Thank you so much, Dr. Lee, and good morning, everyone. My name is Lieutenant Commander Neil Murthy, and along with Dr. Patricia Wody, I serve as the co-lead for the Combined Immunization Schedules Work Group. And this morning, I'm very grateful to have the opportunity to present to you all the proposed updates to the 2023 Adult Immunization Schedule. This is an overview of what I'll be covering in the next couple of slides. I'll present only substantive changes to the 2023 Adult Schedule. Minor grammatical or formatting edits that are meant to improve clarity in the language will not be presented. I'll begin this discussion by walking through the proposed edits to the cover page and tables, followed by discussion of the proposed vaccine-specific changes in the notes section, and finish with a brief discussion of the proposed changes to the appendix section, which lists the contraindications and precautions to all vaccines that are recommended in the schedule. Let's start with the cover page. There are 6 main changes on the cover page. The first edit is to the upper right-hand corner of the cover page, where we have added the American Pharmacists Association as a partner organization approving the adult schedule. The next couple of edits are in the list of adult vaccines. You'll notice that for the first time, we have added COVID-19 vaccines to this list of recommended vaccines. The first abbreviation shown here refers to the monovalent mRNA vaccines. The second abbreviation refers to the bivalent mRNA vaccines. And the last abbreviation on this list refers to the monovalent protein subunit vaccine. In the Hep B row, we have now added Prehevbrio to this list. Similarly, in the MMR row, we have added Priorix to this list. Compared to the 2022 schedule, you will notice that we have combined the pneumococcal conjugate vaccines, PCV15 and PCV20, into one row in this table. And finally, under the injury claims section, we have included information here about COVID-19 vaccines and the Countermeasures Injury Compensation Program. We'll now turn to the changes recommended in Table 1 that outlines the age-based recommendations for adult vaccines. Table 1 has 3 proposed edits. The first edit is the addition of the COVID-19 vaccine row. You'll see here that the entire row is yellow, indicating that COVID-19 vaccination is recommended for adults of all age groups. Guidance regarding the COVID-19 primary series and booster doses is provided in the overlaying text. The second edit is to the MMR row, where overlaying text has been added to the greater than or equal to 65 years of age column. We now refer providers to the notes section for vaccination considerations for healthcare personnel who are older than 65 years of age. And the final edit is to the hepatitis A row, where the overlaying text now states 2, 3, or 4 doses, depending on vaccines, to include the 4-dose accelerated twin risk schedule that can be used for hepatitis A vaccination. Let us now turn to Table 2, which is the medical indications table. Compared to the 2022 schedule, there's only one major change to Table 2, and that is that COVID-19 has been added as a row to this table. The HIV and immunocompromised conditions columns has a C notes as an overlaying text, since such patients may have different primary series requirements and may have additional considerations for pre-exposure prophylaxis to complement COVID-19 vaccination. We'll now turn to changes proposed in the notes section of the adult immunization schedule. In each of the subsequent slides, I'll walk through the notes section and explain the proposed changes in each of the vaccine-specific sections. For your reference, the page number of the notes section can be found in the upper right-hand corner. And we'll begin our discussion with the addition of the COVID-19 section on the first page of the notes section. You'll notice that in the 2023 schedule, COVID-19 is now formally incorporated into the schedules and is no longer in a special call-out box like how it was in previous years. The COVID-19 section begins with the routine vaccination guidance portion that describes the primary series for the mRNA vaccines and for the protein subunit vaccine for the general population. Because guidance on booster dose recommendations may change based on evolving data, providers are encouraged to review the latest booster dose recommendations at the website presented here. The special situations section starts off with a brief description of the recommended primary series for persons who are moderately or severely immunocompromised. Again, a hyperlink is provided here for providers to refer to the booster dose recommendations for persons who are moderately or severely immunocompromised. The last bullet in this section reminds providers to consider pre-exposure prophylaxis in addition to COVID-19 vaccination for persons who are moderately or severely immunocompromised. And the COVID-19 vaccination section ends with a note referring providers to additional resources on COVID-19 schedules and emergency use authorization indications for these vaccines. We'll now move on to the hepatitis B section. As you're aware, hepatitis B vaccination is routinely recommended for all adults 19 through 59 years of age. The descriptions of the 2, 3, and 4-dose series are provided here in the routine vaccination section. Compared to last year's schedule, these descriptions have been slightly revised. Any reference to the 4-dose series for persons on hemodialysis has been moved to the special situations section, which we'll see later in this Hep B section. PreHevbrio was also added to the description of the 3-dose series. And the note at the end of this section states that Heplisav-B and PreHevbrio are not recommended in pregnancy due to a lack of safety data in pregnant women. The hepatitis B section continues on to the second page of the notes. 2 bullets have now been added here describing the recommendations for persons 60 years of age and older. The first bullet states that anyone aged 60 years or older with known risk factors for hepatitis B virus infection should complete a Hep B vaccine series. And the second bullet states that anyone aged 60 years or older without known risk factors for hepatitis B virus infection may complete a Hep B vaccine series. Risk factors for Hep B virus infection are then listed. Minor edits were made in this section to improve clarity in the language. The hepatitis B notes section ends with a special situations section describing the vaccination regimen for patients on hemodialysis. Moving on now to influenza. A sub-bullet was added to the routine vaccination section for persons who are 65 years of age or older. This sub-bullet states that any one of the quadrivalent high-dose inactivated influenza vaccine, quadrivalent recombinant influenza vaccine, or quadrivalent adjuvanted inactivated influenza vaccine is preferred. If none of these 3 vaccines are available, then any other age-appropriate influenza vaccine should be used. We have added the hyperlink to the 2022-2023 influenza recommendations, and we have a bullet for the 2023-2024 influenza recommendations here as well. In the special situations section, we have modified the bullet describing guidance for persons with an egg allergy who experienced any other symptoms other than hives. This bullet now reads that any influenza vaccine appropriate for age and health status may be administered to such patients. If using egg-based IIV4 or LAIV4, administer in a medical setting under supervision of healthcare providers who can recognize and manage severe allergic reactions. We have added a bullet here in the special situations section describing the guidance for persons who are close contacts of patients who are severely immunocompromised. This bullet states that close contacts of severely immunosuppressed patients should not receive live attenuated influenza vaccine. If LAIV is used, they should avoid contact with or caring for such immunosuppressed persons for 7 days after vaccination. We'll now move on to the third page of the notes section, where we begin with the MMR section. The MMR section has only one major addition this year. A bullet has been added referring providers to the guidance that describes administering an additional dose of MMR in the context of a mumps outbreak setting. Finally, because I had mentioned the change in the MMR row in Table 1 earlier in this presentation, I wanted to just mention here that you may consider MMR vaccination for healthcare providers born before 1957 who do not have any evidence of immunity to measles, mumps, or rubella. This is why the overlaying text was added to the MMR row back in Table 1. We'll now move on to the meningococcal section. The only change to the meningococcal section this year is the addition of the guidance highlighted in yellow in this slide. This guidance describes that if the third dose of Tremenba is administered earlier than 4 months after the second dose, a fourth dose should be administered at least 4 months after the third dose. The fourth page of the notes section begins with the pneumococcal vaccination section. Please note that this pneumococcal section does not incorporate today's ACIP vote. Today's vote will be incorporated into this notes section as soon as possible. A bullet has been added to both the routine vaccination and special situations sections, referring providers to the CDC app that providers can use as a resource to help determine a patient's pneumococcal vaccination needs. In light of the ongoing polio response that started this summer, we have also included a new polio section to the notes this year. Although we do state in the routine vaccination section that routine poliovirus vaccination of adults residing in the United States is not necessary, we do provide in the special situations section vaccine recommendations for adults who are at increased risk of exposure to poliovirus. Adults who have no evidence of a complete polio vaccination series should complete a 3-dose series, while adults who have evidence of completing a polio vaccination series may receive a 1 lifetime booster of IPV. Detailed information about these recommendations can be found at the hyperlink presented here. The last section on page 4 of the notes is the Tdap section. Here, minor edits were made in the guidance listed under the special situations section to improve clarity in the language. And this language now states that for persons who previously did not receive the primary vaccination series for tetanus, diphtheria, or pertussis, they should receive 1 dose of Tdap followed by 1 dose of TD or Tdap at least 4 weeks later, and a 3rd dose of TD or Tdap 6 to 12 months later. We'll now finish with the final page of the notes section. A few changes were made to the zoster section this year. A note was added at the end of the routine vaccination section, providing some background on serologic evidence of prior varicella. This note reads, serologic evidence of prior varicella is not necessary for zoster vaccination. However, if serologic evidence of varicella susceptibility becomes available, providers should follow ACIP guidelines for varicella vaccination first. RZV is not indicated for the prevention of varicella, and there are limited data on the use of RZV in persons without a history of varicella infection or varicella vaccination. In the special situations section, the language in the immunocompromising conditions bullet has changed. This bullet now clarifies that immunocompromising conditions include persons living with HIV regardless of CD4 count. Additionally, the zoster vaccine regimen is provided here, along with a hyperlink for providers to learn more. Finally, a note has been added at the end of the special situations section to provide some background for persons with immunocompromising conditions who do not have a documented history of prior varicella infection, varicella vaccination, or prior herpes zoster. This note reads, if there is no documented history of varicella infection, varicella vaccination, or prior history of herpes zoster, providers should refer to the clinical considerations for the use of RZV in immunocompromised adults aged greater than or equal to 19 years and the ACIP varicella vaccine recommendations for further guidance. And that resource is hyperlinked here. Let's now turn to the appendix section that lists all of the contraindications and precautions to each of the adult vaccines. To see changes in the appendix section, let's zoom in and look at the subsections on this appendix in detail. The first change is to the header of the appendix table, where we have changed the header of the contraindications column to contraindicated or not recommended. And just like last year's appendix, the first page of the appendix lists all of the contraindications and precautions to the influenza vaccines. You will notice that the precautions column no longer lists having an egg allergy in the precautions column, since any influenza vaccine appropriate for age and health status may be administered to persons with an egg allergy. The second page of the appendix lists all of the contraindications and precautions to all of the non-influenza vaccines. Again, let's zoom in here to see the edits to the second page of the appendix. In the Hep B row, the language regarding pregnancy has changed. The language now reads that Heplisav-B and Prehevbrio are not recommended due to the lack of safety data in pregnant persons. Use other hepatitis B vaccines if Hep B is indicated. The language for the pregnancy row, the language for pregnancy in the HPV row has also changed. The language now states pregnancy HPV vaccination not recommended. With that, I'd like to thank you all so much for your attention, and I'll pause here for any questions. Thank you all so much.
Thank you, Dr. Murthy. This presentation is now open for questions. I actually have two for you. One is on the slide that, oh my goodness. Actually, I'm going to see if anybody else has questions because I want to find it for you. Oh, no. Sorry. That was a lot of slides. On slide, I think it's 65 in our PDF, Table 1, Hepatitis A.
Yes.
My question is really, it says 2, 3, or 4 doses depending on vaccine, and I'm assuming that's because it's tied to the hepatitis B vaccine, but are we really recommending 4 doses of hepatitis A vaccine?
This is just to accommodate for the dosing regimen if you use Twinrix. So that would also confer protection with hepatitis A. So that was just to be comprehensive and to include that regimen. That was the reason for that change.
Okay. It might, like, I think from a recommendation standpoint, to me it would be clearer if we said, 2 or 3, and then, but 4 is acceptable kind of a thing. Because I don't believe we have a recommendation for 4. We have a recommendation for the combined vaccine.
Okay. Yeah.
Just to consider.
Okay.
And then my other question was, since COVID vaccines are on the schedule, should we also include them in the contraindications precautions section? Did I miss it? I apologize if I did.
Yeah. Yes, we discussed adding that in the table in the appendix, but in discussions with vaccine safety, they are reviewing those contraindications and precautions, and there might be an update before the 2024 schedule. So we decided not to make a change at this time.
Any other questions, Dr. Cotton?
I have a question on Table 2 with the new COVID. So it says see notes for immunocompromised and for various HIV populations, but then it's blank to the right of that. And I guess I would suggest considering putting in the same language as Table 1 where it says 2 or 3 dose primary series and booster, see notes, but just for clarification. Seems like that was sort of left off. I can show you.
Yeah,
I can
that
show
would be
you
helpful.
manually too. I just want a copy and paste.
Thank you, Dr. Cotton. Yeah.
Thank you.
Dr. Goldman?
Thank you. Excellent presentation. I have a question on the note section for hepatitis B. For 60 and above, where it says may receive. For clarification, I think in the past it said anyone seeking protection from hepatitis B. I'm just wondering if we can clear up that language a bit, because it's very vague when it says they may receive it. But why would they receive it after age 60? You know, in the past it's been for seeking protection. So I don't know if we can just clarify that a little for those who don't have the absolute indication of risk versus age. And that's my only concern with that.
Thank you, Dr. Goldman. We can talk to the hepatitis B folks here about that suggestion.
I don't see any additional hands raised. Just to go back to the COVID-19 comment, I think, well, I would appreciate it if recognizing there's constantly dynamic changes that happen, if we could link back to the, at least the clinical guidance or something in the schedule, just so people can look it up and link back to the original.
So there is a link on the, in a box at the very top of the appendix that links providers
perfect.
to the contraindications and precautions for COVID-19 vaccination.
Okay.
But I mean, once, you know, we hope to incorporate that formally as a row in that appendix once we're able to.
Thank you very much. Okay, I can't believe this, but we're not only running on time, we are a little bit early. Are there any additional questions, clarifications? I'll open it up to our liaisons. Okay. Well, I'm going to ask that we reconvene at, I'm going to oh. Gosh, we didn't finish. Apologies. Dr. Paling.
I would like to make a motion to approve this with the recommendation, with the considerations that have been discussed. Thank you.
Thank you. I got too excited. Do I have a second? I'm going to go with Dr. Sanchez. Dr. Sanchez.
I'd like to second the motion.
Thank you. Is there a vote language that we can just clarify and put up about the adult and childhood immunization schedules, please? Here is the language for the vote, just to approve the recommended child and adolescent immunization schedule, US 2023, and the recommended adult immunization schedule, US 2023. So Dr. Paling moved, Dr. Sanchez seconded. Any concerns? Okay, terrific. We have this motion on the table for a vote later today, and we will now break until 25 minutes after the hour. Thank you, everyone.